Hi everyone, thanks for joining us on the Targeting Care and Advancing Analytic session this afternoon. So our first speaker in this session is Daniel Slater, and he's going to be talking about using linked NHS datasets to rapidly generate insights into suicide deaths and prevention opportunities. And Daniel's talk will be about 10 minutes long, and so we'll have 5 minutes for questions. But over to you, Daniel.
Cool, thank you. Hi everyone, I'm Dan from Birmingham City Council, and today I'm going to be talking about using linked NHS datasets to generate insight into suicide death. Just as a disclaimer beforehand, we are going to be speaking about suicide, so if you find any of those topics sensitive, here's some support lines, and please feel free to drop out at any point. So kind of a background to this project is obviously suicide is a national public health priority, and prevention really depends on understanding sort of the key events leading up to each death. And the tricky bit is that suicide, there's lots of complicated reasons. It's sort of a multifaceted problem, and lots of different factors can be missed if you just look at instances through broad statistics. And our kind of solution and way of addressing this is to use a quarter report to allow for quick, repeatable insights that can also sort of give a more holistic view of people's deaths. So the data. For our data sets, we kind of linked lots of information from Aristotle, which is the BSOL ICV's remote desktop platform. And we kind of looked at emergency department attendances, hospital admissions, emergency service calls, prescriptions, and mental health care contacts. All of these being linked around people who've died in Birmingham and Solihull from 2020 onwards. So the kind of main, oh sorry, I don't think my screen's been sharing. Yeah, just to go like that again. So we've linked all these data sets together and kind of got this joint view. So sort of one of the main benefits of this is it lets us look at information in a way we might not be able to otherwise. So with the kind of demographic information of people who've died, a lot of the cases in the deaths register, it might not be coded there. But since we're linking a lot of these data sets together, it allows us to kind of see the ethnicity from previous instances and kind of get that data where it might have been missed otherwise. On the right here, you can see a bar chart of the people who've died by their ethnicity. And you can see at the top here, this is kind of another advantage of using Quarto, because this sort of commentary, this narrative is kind of generated as data is pulled into the report. So we can see there's 620 registered suicides. You can see the average age and ethnicity and method of suicide. And all of this is completely repeatable as we pull the data from the SQL server. One of the sort of standard things it can do is produce these standardized statistics on the BSOL deaths. So we kind of see that from age bands 30 to 60 are kind of the significant age bands. And with our kind of ethnicity data, we can do this for ethnicity as well. So here's another graph showing sort of the standardized rates by ethnicity for males, and we can see white British is the only statistically significant one here. So the real, I'd say, kind of useful bit of linking the data sets like this is we can get these really high-level overviews of how these people are interacting with the health system and sort of potential places of intervention. So what the bar chart on the right-hand side is showing is the percentage of the people who've died who've had at least one contact with the health system through these different avenues. So we can see that through physical health prescriptions, 50% of the people who died had at least one prescription given to them in the 12 months for their death. And we can kind of see that across all these different data sets we've pulled in. And again, at the top here, we've kind of got this high-level overview of how generally speaking, how many people have had some form of contact with the health system. So we can see that 78.5% had some form of contact through one of these sort of different avenues in the data set. And just to kind of show a bit how we can look at this over time. So for each of these sort of contact areas, this one's showing mental health care care contacts. We can look at it per month, and then we can kind of get a general idea of the sort of pathways people go through when interacting with these services. So sort of a general trend in this graph is the closer time to death, the more people have scheduled care contacts. So you can kind of use that across the different data sets for whatever insights you're kind of looking to develop in that way. So this is kind of what I talked about earlier with having things more than just broad statistics. And what we're able to do with these data sets is sort of get individual level, patient level timelines. So whilst it's hard for those broad graphs to kind of see an individual patient's journey, we can kind of automate the process of creating these timelines, and we can see all the sort of interactions with the health system for a single patient across the year before the death. So here's an example on the screen now. For example, the green points and the pink points are physical health prescriptions, mental health prescriptions. We can see in this scenario they had reoccurring prescriptions. At the top, we can see their care contacts. The red points where they've missed care contacts. So we can see they've missed a few contacts before death. And the good thing about this being in a quarter report, I can't show you in the PowerPoint, but this is also interactive. So you can hover over, and then on each of these points, you can kind of get a bit more information about these events. For example, maybe for an ambulance call, you can see the subject of a call, or the emergency department attendants, you can kind of see why they attended the emergency department. And this is kind of in collaboration with the broad statistics, is kind of giving us that more holistic view we're aiming to achieve. And yeah, we can generate these for all the deaths in the data set using their pseudonymised NHS numbers. Another sort of aspect of a report is the mapping of these deaths. So obviously on the death register, we've got access to their sort of place of residence. And when we combine that with calls to 999 hospital data, we can see when a suicide occurred outside the place of residence. And by doing that, we can map these and sort of look for potential points of intervention or potential places where additional safeguarding might be useful. For example, if lots of the blue points, which indicate a suicide by drowning, were near certain bodies of water, maybe you could make a case for some sort of additional safeguarding in those areas. Just to touch a bit on the limitations of the data. So I think the major flaw we kind of had to grapple with was that there is no specific date of death in the data set. And since we're looking at prevention opportunities, it can sometimes be hard to filter out events that might immediately precede someone's death that aren't actually a prevention opportunity. We did manage to resolve this in a way where if someone had an ambulance call for peri-arrest, so their heart stopped, we can sort of get a predicted date of death, but it was definitely a limitation in how kind of useful we can make those graphs. And sort of something for further work, a full understanding of suicide kind of requires, it's good to have all this data about health, but there's probably some aspect of social and economic data sets that we could link in and maybe get an even better understanding of sort of the people who've died and their pathways, and sort of more stuff to understand these people's individual conditions or economic status would be useful, I feel. So just some takeaway conclusions. So linked data sets can be really powerful. We've managed to do some things in this report that can be hard to do otherwise, and done some really unique things. And I think the mix of sort of mediums works quite well in painting a better picture. You kind of get the broad stats and individual timelines. It's give you the best of both worlds in sort of helping you understand these people's pathways. But just to caveat that, our insight can only be as good as our data, and sort of incorporating more complex data sets or improving the ones we already have are sort of ways we can take this project sort of further than it already is. So yeah, thanks for listening. Many thanks to Birmingham and Solihull mental health teams, and for the BSOL ICB for continued work of the project. If you're interested, please get in touch. I've got a link to the GitHub there, which has the SQL code to extract the data if you have access to Aristotle, and some code to help create the timelines and the graphs. And yeah, that's it. Thanks. Are there any questions?
Thanks very much, Daniel. And yeah, questions coming in thick and fast. And I should have introduced myself properly at the start. I'm Gordon, Director of the Administrative Data Research UK programme. So all of this talk about linked administrative data to support informed policy decisions is music to my ears. And I remember some research from Scotland a few years back that made that link between it being a risk factor if people with mental health conditions start missing appointments. And have you done any analysis on whether that is actually a risk factor for suicides? Because I noticed that you had those missed care contacts in there.
Yeah. So sort of in the report we have these. I showed one, so the kind of the months before death timelines. So inside the report it has those for sort of the care appointments. We've got different tabs for the cancelled care appointments, attended. I won't make any statements on conclusions you can draw from that, just because there's lots of different caveats to sort of the data. But all that sort of stuff is sort of in the report, and you can generate those using the sort of linked data sets quite easily.
Yeah, that's really useful, and to inform policy, because I know it was something that the NHS were looking at, whether there should be charges for missed appointments, but clearly if it's a risk factor for suicide, that's not going to be particularly helpful. But we'll go to the questions in the chat now. It's a question from Liliana Valles. Said, what methodology did you use for the linkage? Yeah, and what linkage quality was observed?
Yeah, so essentially what we did off the, I think it's the SQL set called the VW def register, and we extracted all ICD-10 codes where it was suicide or suicide of undetermined intent. And from that, we used their pseudonymised NHS number, and then through all these different data sets I listed, we essentially extracted their attendances via their pseudonymized NHS number. In terms of quality, I guess I'd take that as quality of the data. So we did have
linkage quality. If there was a lot of records that didn't link, I'm guessing.
Oh, I think it's tricky, obviously. If they didn't link, it would be hard to know about it, because obviously we wouldn't pull them through. But we can see from their pseudonymized NHS number if they pulled through, and it seemed like we did have a good broad coverage of the people who died.
Excellent. So a couple of other questions. One from Sharon Makatia. We use suicide audits assessing coroner's reports. I'd be interested in comparing our approach with yours, as we are pulling out similar findings. And have you used coroner's reports in the past? If yes, why did you change approach?
So in terms of sort of other approaches, I've been put in this project to sort of work with Richard Wilson from the BSI ICB to kind of use their data. It's not something I've worked with sort of in the past in terms of coroner reports and things like that. But I think my understanding is those can sometimes be kind of tricky to develop, or they take a bit of time. So the approach we're looking at is being able to do it really quickly using the sort of routinely collected data sets to try and do that at rapid pace, essentially, via the patient timelines that I had shown. But in terms of changing an approach, I've not worked with those myself, so I can't comment on that.
Yeah, and when I was at ONS, we did some work on the coroner's reports, particularly the narrative reports, but really tricky because a coroner can write a whole essay about a death, and then pulling out consistent information can be very tricky. We should probably move on to the next talk. Thank you very much, Daniel. Really interesting talk. Loads of comments in the chat and the Q&A, so please do feel free to answer those in the background.
Will do. Brilliant. Thank you.
So waiting for the next present. Oh, waiting for the next presenter so we can go back to one of the other
Okay, cool.
questions. So yeah, just looking at the attendee chat. So there's a question around why didn't you have access to their date of death if you as your start point was extracting the suicide or undetermined deaths?
So we in the data set it just had the year and the month they died. So we had the month, just not the specific date of death. So yeah, so that I think it's kind of when we want to see events that maybe happened literally like a week before they died. It's tricky to do that when we just have a month. Yeah, that's all I meant by don't have the exact date of death. Yeah.
Yeah, no, that makes a lot of sense. I'm just going to go back to the Q&A chat. Did you run into any challenges when you're linking data, and how did you overcome them?
I think we did have a few just using the remote desktop platform. I think there were some issues around sometimes. Essentially, working with Richard Wilson on this, so we'd run the same SQL code and get different different data sometimes, which is weird. I think it was some sort of access issue on the actual platform, just how my account was set up. So we managed to resolve that. I think that was probably the sort of main challenges. But yeah, apart from that, I think everything was relatively easy using the since we have the pseudonymized NHS number. Yeah.
Excellent. I think we'll stop there because in the attendee chat, I can see that Mohammed Hussain, who is our next presenter, is actually in the audience, but he's trying to become a presenter. So I don't know whether there's anyone backstage that can help with that.